Okay, so hi, Dr. Nikita Vizniak here, and I'm here with the amazing
Dr. Katherine Chung.
And we are going to demonstrate some variations of adjustments for you guys so that you can use this for your studying for class, for board exams, and dare we even suggest for patients. But the difference that we're going to offer is I am 180 centimeters or 6 feet tall, and she is?
I'm 150 centimeters, which is 5 feet tall.
And we're going to show the variations in biomechanics as we move through these different adjustments. So without further ado, we'll go ahead and start with a basic adjustment that's going to be a simple prone thoracic adjustment. So I'll get Katherine to lay face down for us here. So a couple of key things. I always make a joke about this, but if you care about your patient, the first thing you do is you lay the headpiece down for your patient. The next thing that you're going to notice that I'm doing is my body weight stays over top. So basic assessment, I'm in a fencer stance right here to begin with. Lay your hands over top and I can go bilateral thenar or bilateral hypothenar. Either way, I'm going to tissue pull I to S and just gently walk up and down the spine. Now my standard joke here is the Luke spine walker, so I wind up loading in, loading in. Notice that my hips are relatively close to my hands. I see a lot of people do this and they're reaching far back like this. It makes it way more difficult for you to do that. So if I load in, I just bring my body weight over and sink in and sink in. And in fact, Katherine, you got a little bit of tightness right there. Can we go ahead and just adjust right there?
Sure.
All right, so big breath in. And she breathes all the way out, sinking down, 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 and a little bit of overpressure. And it's as simple as that. So I to S, hips drop, good movement all the way through. So now I'll have the amazing Dr. Chung demonstrate this.
So as someone that's a little bit smaller, mechanics are going to be a little bit different. However, the setup is still going to be the same. So the tissue pull is still going to be I to S. And I tend to do a hypothenar across bilateral on the hypothenars as you're pushing through. Instead of having more of a fencer stance, I like to square up a little bit, and this gives me a better center of gravity, and then I am a little bit more specific in where I want to be, and then I just can thrust through coming down, almost like a CPR type of motion, where you're really getting your body and your center of gravity over your hands. So, Dr. Nick, you seem to have one fixation here. May I adjust that?
Absolutely.
Perfect. So he takes a deep breath in, and out, and then can just drop through just real quick right there. Yeah. And there's another way that I like to do it as well. Would you like to?
I absolutely want you to do this, and I think this is really important for everybody to see this. I call this Katherine's thunder drop right here, so we'll go ahead and see this. Yeah.
So as a warning, this is for someone where you're small and very small frame like me versus say like a football player, someone that's quite stiff. So more of a geriatric back, or someone that's much bigger than you in terms of muscle mass. You do have to control the weight a lot more though, because there is a lot of power that's going to go through this. So the setup is still going to be Carver bridge over the thoracic spine, and then it's still going to be an inferior to superior tissue pull. Instead of just having a straight arm and then you coming through like this, I'm going to actually bring my sternum over my hands and drop through the rest of the body. So it's going to be a quick impulse here. So Dr. Nick, I'm just going to adjust you right here, okay? Okay. So he'll just take a deep breath in and out, and IS here, and then drop through. And then your full body weight just comes right through, and you do have to be careful, like I said, because it is a lot of power right from the get-go right there. So
yeah, I'll just make a couple comments on that. So all of her setups that she did, the adjustments she did, this is kind of funny because me sitting down, we're almost the same height here, right? Okay. Is all the adjustments she did, she had successful cavitations and mobilizations with those, and they were very well controlled. So very good advice for a smaller practitioner. For larger practitioners, we tend to have an advantage just because of body weight and biomechanical length and strength that we have. So excellent to see that. So we'll go ahead and switch this up now and do some supine thoracic adjusting. So we'll show supine thoracic for basic vertebrae and for the ribs super quick. So if I can, Dr. Katherine, we'll get you to lay on your back here. Headpiece up just a little bit. Okay, so a couple of key things. The first thing is when you're setting up, initially what I generally say for a taller practitioner is why don't you go ahead and take a knee to start with, and this knee can be on the side of the table to go ahead and support and actually make the table wider. So when you roll the person over, they're not going to fall, and they'll feel just a little bit more comfortable when you do that. The next thing is patient can hug their arms so they can give themselves a hug. Generally, it's better to have the elbows stacked over top like this. And the last thing, of course, is going to be this leg can be lifted up, and that makes it easier for the patient to roll over before you. This is your starting position right here. Another key thing to watch out for, and she's in a good position right here, is if their shoulders are too high on the headpiece, then you're going to run into trouble as you try and put them back. So from here, okay, what I'm going to do is just expose her back so we can roll her over to the side, and she actually is on my leg a little bit right now, which is fine. If you have bigger people, again, she'll do this variation here in a little bit, but if you have bigger people, this is a good way to control them. My tissue pull here is going to be S to I, and I'm going to have a light force there. She's going to do a big breath in. She breathes out. I tuck her down. My elbow hits the table. I get up over top so her elbows are into my abs, and I slowly traction up, 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 and then my hips drop through her body like that. And we did have a release on setup right there. I'll just demo it again from the opposite side so we can see really how the body needs to move. Been doing this for about 20 years now, training students, so a couple of key things to get, and actually Katherine, I'll get you down the table just a little bit. A couple of key things to get when you're setting this up is when you roll the patient over, you put your hand over their hand, bring them all the way over, tissue pull. She takes her breath in again. She breathes out. I have to make sure that that force is going into lengthening her whole torso up and not just pushing into her shoulders like that. If I push into your shoulders, what do you think?
Not fun at all.
Not fun, yeah, not fun at all. You can actually dislocate a shoulder if you do it like that. So you want to maintain that tissue pull down. The other thing that I see a lot of students miss is watch the way that my hips and leg move, is you drive with your whole body like this. Instead of just your upper body pushing down, full body drive forward. That full body drive forward is going to give you the advantage that you need to move patients around. So we'll get Katherine to demonstrate this now too.
So with shorter practitioners, I don't necessarily get that extra length that, say, Dr. Nick has. So when he was setting up, the setup is exactly the same, right? So they're going to hug each other, or hug himself, sorry. And then you're just going to bend the knee up like this. So the basic setup is all the same. However, Dr. Nick, he will start on his knee. However, you can see this is way too short for me, so I tend to have to start in a squatted position. And I'll show you what my legs will look like after I show you the rest of it here. So I'm going to start standing up, and then the same contact is going to be the same. I'm going to roll him over, and my leg is right here, so it's going to catch him, and there's just no way that he's going to fall over either. So the tissue pull is going to be exactly the same as the other, what Dr. Nick was showing, so it's going to be a superior to inferior, and then you're still tucking as well here. I like to tuck not midline like Dr. Nick does. For me, because I'm so small, I tuck more along the rib cage here, but I have to add a little bit of a tissue pull on top so that I'm not hooking into my own rib cage, and that hurts a lot if you miss that.
Yeah, and that's a really good point, right? So many people get the elbows into them and they jam into their own ribs.
Exactly.
Yeah.
And that's just that you can potentially actually really injure your rib, right? And actually potentially fracture it if you put enough force into it, which we do want to protect ourselves and have a long career here.
Yeah, awesome.
So again, it's going to be an S to I, and then he's going to breathe in, and then out, and then through here, and then you can just thrust through. If your patient is a little bit thicker in terms of the arms and then also the body, then what I like to do also is to just take the one arm out, and that just decreases the actual width of that person way more. Like, this is a ton of space that you can take out, and you're just gonna confidently put it on your back. Don't make it weird or anything. You just place where the hand is gonna be, and then the patient knows, okay, this is where the hand's gonna be. And then the tissue pull and the setup is going to be the same here. So take a breath in and out, good, and then up, and then through like that.
Yeah, and one big point to make on this, with this arm out of the way, it maybe makes the person 20% thinner, I would say, right? Yeah. Okay. All right, you want to just demo on the other side too, and we'll see that.
So in terms of the legs, this is the most important. This is why I want to do it on this side and what my legs are looking like when I'm adjusting. So stacking here, or you can take the one arm out and then put on your back right here. When you roll them over, this is what I was talking about, where the leg really does stop him so he can't roll over. And then you have to start relatively low though. So when you're tissue pulling in, you see how my legs aren't open, and it's not like a fencer or warrior stance. You really have to bring almost your knees together, and you're really dropping those hips. So then when you tuck in, and then he breathes in and out, and then you roll, then this is where that forward thrust comes through, and you can really just push and on top and forward into your adjustment. And that's the lengthening that Dr. Nick was talking about.
Yep, excellent. And another key thing there that she did really well that you have to do with a patient is when you have the patient breathe in, don't have your body weight on them, okay? So many people do that. It's like, take a breath in, like, I can't breathe, okay? You've got to give the patient room to breathe. All right, why don't we go ahead, we'll switch over to some basic rib adjusting from a supine position. So we'll switch doctor and patient here again. So I am a big fan of supine rib adjustments. You have the advantage of using the patient's own body weight plus your body weight. Generally, you can get a little bit better distraction. I just think it's the way to go for most rib adjusting. Yes, there is application in other directions as well, but maybe it's my own personal bias after 20 years, but it's just something I find more comfortable for patients as well. So same setup as before. Leg is up, arms are going to be crossed over, but we want to do a little bit of a variation here. So what we're going to do is bring the patient all the way over, mark that rib, and again, if you want, that leg can be up, but you're going to mark the rib, and this is the key thing to get, is where my finger marks the rib, I go and I slide above that, and my tissue pull is S to I and M to L, where I load out, and I just give a little bit of a pull onto my onto my thenar eminence. Now the key thing here is my hand is relaxed. I'm not actually starting with a really sharp contact, I'm just nice and relaxed here to begin with. And when I roll the patient back over, I'm relaxed, 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 but I have to roll the patient past center to reach that rib. And it's only a little bit past center, but that's it, okay? So we'll do this for real. So she has a big breath in, lots of space, she breathes out, tissue pull in, loading over, over, over. If I want more pressure, I can push on her shoulder all the way in, and a little push right there, okay? Very specific, to the point adjustment. I mean, yeah, okay?
Exactly.
Yeah.
Perfect. And same setup is going to be for a smaller practitioner as well. The only difference that I would really change outside of getting the arm out like I did with the supine thoracic is where your hand is going to be when you're rolling them over and then you're adjusting them. Here. So like Dr. Nick was saying, so you're going to roll them over and then the tissue pull is going to be exactly the same. So S to I, M to L. And then you're gonna hook in. Actually, what I'll get you to do, because the table's a little bit on the wider side, I'll just get you to be closer to me.
And that's a huge tip there too, right? Like if the person's not centered in the table, then you wind up fighting the table at the same time. Move them in a position that works better for you.
Exactly, especially when you're shorter and like you already have a length disadvantage. You want them as close as possible so you have that distance advantage there once they're set up closer to you. So S to I, M to L, and then he's gonna take a breath in. And out, good. And then I like to put my arm across the shoulder and then I grab the table like this, so then I can then drop through.
So just keep that set up because I want to point this out. This is absolutely huge the way that she does this. This extra grip, she's giving me shoulder pressure right here with her forearm, and then that gripping onto the table, I feel like you gain an extra 30 or 40% of strength on that rib by doing it this way.
Exactly. And then that, because I'm so short and I'm like on my tippy toes, there's not much force I can generate moving forward like this. So actually having this extra 30% does a lot more, because then my thrust can be a little bit lighter, but still have the same effect therapeutically.
Yep, awesome.
Good.